Paramedic Special Populations, Chapter 45, Patients with Special Challenges, Part 4, Medical Technology in the Pre-Hospital Setting. There are many invasive, unusual, or life-sustaining therapies in patients' homes and long-term care facilities. Chronically ill patients are cared for at home by a range of caregivers, including family members, unlicensed caregivers, licensed non-professional caregivers, licensed professionals, and a combination of the above. Many family members are medically knowledgeable and a paramedic's best source of information and care guidelines. Medical technology and adaptive devices during an EMS response or interfacility patient transport may simplify, complicate, or have no effect on patient care. You may need to troubleshoot the devices as well. If at any time you are unfamiliar or uncomfortable with a particular device, you should not blindly try to troubleshoot a device, and you should not blindly try to utilize the device. You must remember that most patients, when they're able to care for themselves and their caregivers and family members, have to have very intensive training on these home devices before they are allowed to be discharged from the hospital. In most cases, they actually have to show back competencies on these skills, just like many of you have to show competencies on your skills in order to be discharged with the trust of the medical facility. So the first device we're going to talk about is tracheostomy tubes. So tracheostomy tubes are long-term replacements for ET tubes. They can be used for long-term ventilatory support, sometimes in cases of a patient who is admitted to the hospital and is intubated and on ventilatory support. And over time, roughly a week to 2 weeks, the latex in the balloon of the ET tube actually starts causing ischemia and breakdown on the mouth, the tongue, and the tissues of the throat. So in this case, they may elect to do a percutaneous tracheostomy. If a patient needs frequent tracheal suctioning, or if they just need airway protection and they're not able to maintain their airway due to upper airway issues, the tracheostomy device that you see right here, this is actually called a Shiley. And if you notice here, there are two pieces to this device. So this device right here, where the wings are, and then the tube with the balloon, this is actually the outer cannula. This is what's actually inserted into the tracheostomy hole, and the balloon works very similar to the balloon of an ET tube. You have the inner cannula. The inner cannula is clipped in or snapped in, and it is changed frequently because you've got to remember with tracheostomy tubes, you're bypassing the body's natural filtration and humidification functioning. So these patients are going to be more prone to infection, such as pneumonia. They're also going to be more prone to mucus plugs and unable to expectorate the mucus. So in a lot of cases, the first thing that needs to be checked is the inner cannula, which is seen here. So Shileys come in several different sizes based on the tracheostomy size or even the patient size. Another thing to note on tracheostomy tubes is that if that tube is lost, if it is not secured and it falls out, it's most likely not going to create an emergency as long as the stoma is still patent and you're able to ventilate or the patient is able to breathe. Patients may also tolerate ventilator support interruptions for a period of time. There are some patients that are completely dependent on the ventilator, and its loss of function may be an immediate threat to life. Tracheostomy tubes can be placed frequently by healthcare providers in cases of profound upper airway obstruction. They also, as I mentioned earlier, may be electively placed in patients who are already receiving mechanical ventilation by ET tubes or with slowly evolving upper airway obstructions or tumors. This tracheostomy tube is secured mainly with just this bulb right here, and then it has a tie, so it's not sutured in. It is that way so that it can be changed out, cleaned out, and replaced. Just as I mentioned earlier, you have the outer cannula, the inner cannula, and the orbitator. The orbitator is right here. The orbitator actually goes in and it actually occludes airflow in cases where maybe the patient is trying to wean off of the tracheostomy tube. The tracheostomy tube may be fenestrated or even have a fenestrated cap. This is when patients are being evaluated for tube removal, and so it actually allows for the patient to be able to speak, breathe, or clear upper airway obstructions or secretions. The term fenestrated simply means holes or openings present in the outer cannula or both inner and outer cannulas. It's essential that cuffs are deflated before a fenestrated tube is capped. And then there are situations where patients can communicate by talking by simply occluding the cap or the top of the tracheostomy tube. Patients and family are likely to be familiar with the tracheostomy tube problem, so you've got to remember that with the tracheostomy tubes and also with a lot of these other medical devices, if these patients are calling 911 in reference to an issue with that, they've already tried all the troubleshooting that they know. So in a lot of cases, the main thing they need us to do is supportive care and get them to the hospital. For troubleshooting, you'll follow the DOPE acronym. You want to check the device. Is it dislodged, displaced, or disconnected in the case of artificial ventilation? It is possible for the tube to end up in a false lumen, which is outside of the trachea, after removal and reinsertion or partial removal. So remember, in many cases, these things will be taken out from time to time, and the intercannula will be taken out, and trach care will be done pretty frequently, at least every 12 hours. The next letter is O in the acronym, obstruction. We want to make sure that there is not a mucus plug, that there is not something else there. Removing the inner cannula, then using a suction catheter to push out the mucus plug. Using a combination of tube suctioning and mechanical ventilation. You can actually take around 3 cc's of sterile normal saline if you're having trouble with breaking up real thick sputum, and squirt some down and go in with a soft catheter and suction that back out, and that should help break it open. Pneumothorax. Remember, you're losing airway distance, and in this case, either if mechanical ventilation starts providing too much pressure, or in the cases of using a bag valve mask, you may cause a pneumothorax. And in some cases, a patient may just form a bleb and a spontaneous pneumothorax may be created. If the only available tracheostomy tube is lost or unusual or unusable, carefully insert an appropriately sized endotracheal tube into the tracheostomy tube opening, which is called the stoma. Techniques to ensure correct placement include using a bougie, a glove finger, or you could use hemostat guidance. In most cases, the stoma is going to be pretty well patent. You shouldn't need to have to use hemostats. And in this case, placement is confirmed with a combination of end-tidal CO2, breath sounds, ventilation compliance, chest rise, or clinical improvement. Equipment, we want to make sure that the equipment is connected and that the equipment is properly functioning. The best advice that I can offer to you is in the case of a patient who is starting to experience airway compromise, who is mechanically ventilated, is to disconnect the ventilator and start providing bag mask ventilations. Here are the steps for cleaning a tracheostomy tube. Remember, you need to have sterile water, sterile gloves, and a sterile suctioning kit. Remove the inner cannula and place the device to soak in proper solution, or just get a new inner cannula. Attach the catheter to negative pressure. Check suction and clear the catheter by drawing up a small amount of saline. Have the patient take a deep breath or pre-oxygenate the patient using the ventilator. Insert the catheter into the trachea without suction. Apply intermittent suction while removing the catheter. You can repeat this as necessary. Then you want to have some saline available or sterile water to clean the inner cannula. You can use a tracheostomy brush, rinse and replace and lock into place. And you can then suction some of the sterile water through your suctioning to clear it out. Next on our list are long-term ventilators. We've already been discussing this. Patients may be on long-term ventilators at home for many reasons, including spinal cord injury, neuromuscular disease, or lung injury. Your primary assessment includes determining if the ventilator is working effectively. If it does not appear to be working effectively, work to adjust the ventilator settings, disconnect the ventilator completely, and again, if you do disconnect the ventilator completely, then you need to be prepared to provide adequate bag valve mask ventilations. Normal oxygen levels for patients with long-term ventilators may be below what is considered normal for others. Some medical conditions can be made worse by overly aggressive oxygenation and ventilation. If the ventilator does not appear to be working effectively for the patient, work with the patient or caregiver to adjust ventilator settings. Understand the clinical impact of ventilator changes before attempting adjustments. If you disconnect the ventilator, disconnect it completely, and again, be prepared for bag mask ventilations. CPAP and BiPAP or BiPAP devices. You should be very familiar with CPAP devices, continuous positive airway pressure, and bilevel positive airway pressure devices. They offer non-invasive options for oxygenation and ventilation support. Sometimes diaphragm and phrenic nerve stimulators allow some patients to breathe without ventilator assistance, but they may need the assistance of CPAP or BiPAP. External electrical impulses in the nerve stimulators cause the diaphragm to contract, then passively relax. Movement creates enough tidal volume for effective respiration. If devices fail, you can use conventional bag mask techniques. Asynchrony may occur between mechanical ventilation and patient breathing if the device is activated while patients are receiving bag mask or ventilator assistance. Devices consist of a small box connected to wires inserted into the anterior lower chest or upper abdominal wall. Moving on to ventricular assist devices. You may also see this as a left ventricular assist device. Ventricular assist devices, or VADs, provide life-saving bridge for patients with severe heart failure. In a hospital setting, VADs are placed in a patient's chest during or after heart surgery to help a failing heart perform. VADs are now portable and can be used by people in the community. Few interventions are available for EMS, correcting problems with battery or power supply, providing supportive treatment, or providing immediate transport. Complications of ventricular assist devices include bleeding, infection, and device failure. As mentioned earlier, there are few interventions available for EMS, but of note, American Heart Association has changed their stance on compressions in the event of cardiac arrest. In the event of cardiac arrest with a patient that has a ventricular assist device, the American Heart Association does recommend performing chest compressions. Next on the list is apnea monitors. Apnea monitors are used for infants with high risk or sudden infant death syndrome or other causes of apnea. Diagnosis and evaluation of sleep apnea. The types vary depending on the purpose. Infant monitors usually record an ECG tracing and respirations based on transthoracic electrical impedance. They will detect central apnea, but may or may not detect apnea caused by airway obstruction. Many home apnea devices do not display numeric values or ECG and respiratory waveforms. Essential that ALS resuscitation equipment be used for patients requiring EMS assistance. We never want to depend on a home device to get us the crucial diagnostic or monitoring information that we need. We always want to use our own equipment when managing any patient. Long-term vascular access devices. Long-term vascular access devices are placed for a number of reasons, including inadequate or impossible peripheral IV access, medication administration that irritates smaller blood vessels, vasopressor medication infusion, chemotherapy, frequent blood draws, long-term antibiotic therapy, or dialysis. Many of these devices are maintained with the anticoagulant heparin, some in dangerously high concentrations. If you are unfamiliar with how to use these devices, you should obtain additional training and you need medical director authorization prior to use. The use or the access of these devices, most of the devices, are in the paramedic scope of practice. In emergency situations would be when you would access these devices. If you do access the device, the first thing you need to do is remove any heparin. So essentially you would just aspirate until you got blood once you access the device. Sometimes it requires up to 10 milliliters of blood to be removed and discarded before any of the following: before you flush, before you have medication pushes, or infusion. It is essential that you remove the heparin because if you flush with the heparin, then you're going to provide a bolus of heparin, which is an anticoagulant, which could cause other issues. Contaminated catheters can cause serious bloodstream infections. Sterile technique or port cleaning should be used when accessing these devices. Most of these devices would also be called what you would call a central line, meaning that they tunnel or they end, the lumen ends right above the right atria or in the right atria in the vena cava, which is going to provide all flow from this device straight into the mainstream circulation. So you want to make sure that anytime you access these devices, you are using sterile technique and you are cleaning the port very well. Common devices include peripherally inserted central catheters or PICC lines. These are very common. Midline catheters, double or triple lumen central catheters, Hickman, Broviac, or Groshon catheters, implanted ports, or dialysis catheters. This example here is a PICC line. A PICC line is really long and it tunnels into the patient's body. These are the most common ones. They are long intravenous catheter, usually placed in either arm, most of the time in the brachial or the basilic vein, and it follows the peripheral veins into the superior vena cava. It may be in place for up to 1 year. It's smaller in diameter and a longer catheter length may increase resistance during rapid infusion. This may or may not be flushed with heparin after use. It's very important with a PICC line that you remember that you do not want to use a syringe smaller than 10 cc's to flush because the lumen's so small, the smaller cc syringe could actually cause a large amount of pressure, which in some rare cases it could actually rupture the PICC line. Also, prior to accessing, you want to try to aspirate at least 10 cc's of blood to make sure that you've gotten all heparin out, and then you want to flush with 20 cc's of normal saline prior to medication administration. Once you administer your medication, then you want to flush with 20 additional cc's of normal saline. Because this PICC line is so long, you want to make sure that the medication is actually accessing the venous system. Your midline catheters, as just mentioned, are placed into an upper extremity. They're not as long as they're not as long as peripherally inserted central catheters. So in this case, it does not reach central circulation. It's longer than a traditional peripheral IV catheter. It's better suited for irritating medications, especially some things like propofol or maybe Levophed or some of your vasopressors. And these do typically contain heparin and they don't stay in as long. A double or triple lumen central catheter is placed to the skin in a relatively close proximity to a large central vein. The most common vein sites are going to be a femoral, an internal jugular, or the subclavian. It's placed in an acute care setting, or it may still be in place a short time following discharge or transfer. Usually these contain heparin when not being used for ongoing infusions. Your Hickman, Broviac, and Groshon catheters, these catheters are tunneled under the skin into the superior vena cava. They typically contain heparin when not in use and look similar to a dialysis catheter. Ports may be colored red, blue, or green. Do not use clamps or hemostats on the catheter itself. Implanted ports may also be known as porticaths, or you may hear them call it a power PICC. These are implanted ports which are placed completely under the skin and tunneled into a central vein. They're similar in size and shape to one or two large hazelnuts. The top of the implanted port is flat or slightly rounded with a palpable edge. Ports are accessed with a needle bent 90 degrees with plastic wings to hold while inserting. This needle is called a Huber needle. They contain heparin when not in use. Your dialysis catheter, your VasCath or PermCath, usually is placed in the neck or groin for dialysis. They're thick-walled, high-volume catheters, often only accessible by dialysis nurses or specially trained RNs. Stored with high-dose heparin, they may allow significant bleeding if not capped and clamped properly. Accessing an implantable venous access device is in your scope. You do learn how to access these. You should make sure you know your protocols. You should make sure you know what your scope is. In most cases, it's going to be for an emergency resuscitative situation, such as resuscitation in cardiac arrest or resuscitation in shock. Here is a short video found on YouTube concerning central venous and PICC lines in the medical setting.
Chemotherapy is the use of medicine to kill cancer cells. These anti-cancer medicines are usually given as an intravenous or IV infusion, where they drip into the bloodstream at a steady prescribed rate. Repeated needle sticks into the veins can cause the veins to scar or weaken, making them unusable for repeated long-term use. An alternative is the insertion of a central venous catheter, or CVC. The CVC is surgically implanted into a large vein in the chest or neck and threaded through until it reaches the superior vena cava. The catheter is then secured to the chest. After insertion, the CVC can be used to give IV therapy or remove blood for lab tests. CVCs usually remain in place for a long period of time and benefit patients who need long-term chemotherapy. Another type of long-term venous access is a PICC line, or a peripherally inserted central catheter. Compared to a CVC line, a PICC line is inserted into a vein in the arm or hand. As with the CVC, the catheter is threaded along larger and larger veins until it reaches the superior vena cava. Both CVC and PICC lines allow long-term venous access without having frequent needle sticks. Some treatments can even be given at home with the CVC. Both CVC and PICC lines have a high risk for infection. Sterile techniques must be used at all times.
In this skill drill, you'll have an example of how to access an implanted venous access device, or a porticath. Palpate the skin over the device. Cleanse the skin over the device using a betadine solution or possibly a chlorhexidine solution. Draw up a small amount of saline. Prime the needle tubing and needle with saline. While you are stabilizing the device, insert the needle at a 90-degree angle to the skin until the needle tip reaches the back of the device. Aspirate 5 milliliters of blood. In this case, you're wanting to aspirate blood, but mainly you're trying to aspirate the heparin that it was possibly locked with. Block the flow in the line using the crimping device and then discard the initial aspirate. Obtain additional blood samples as necessary. To avoid air aspiration into the line, never remove the syringe without blocking the flow in the line. Flush the line with normal saline. Administer medications or fluids as directed. After administration of medication, flush the device again, block the flow in the device, and secure the needle with a sterile dressing. Accessing a tunneling device, these are going to be like your PICC line. Use aseptic technique. Prepare all of the appropriate equipment. empty 10 to 20 milliliter syringe. Nothing less than a 10 milliliter syringe should be used. 10 milliliter normal saline flush, sterile gloves, alcohol prep, 10 drip administration set, 500 milliliters normal saline. Ensure all lumens are clamped. Air embolism is a serious risk with these patients because many of these patients have devices that go directly into the vena cava. That is why central lines must be clamped whenever they're not in use. Use an alcohol prep to prepare the lumen that will be used. Attach the empty syringe and withdraw a minimum of 10 milliliters of blood from the lumen. Discard this immediately into the Sharps container. Do not withdraw too forcefully. If you meet some resistance, then gently flush and withdraw. Ask the patient to turn his or her head in the opposite direction of the central line. After you have withdrawn the 10 milliliters of blood, attach the 10 milliliter syringe filled with normal saline and slowly administer it. Attach the prepared IV drip set and set it up for at least 10 mils per hour. Depending on the size of the catheter, you can infuse at a rate of 125 to 250 milliliters per hour. The line must be running continuously because heparin is not available. Administer IV medications through the attached IV drip set. Monitor the patient's condition and document the medication given, route administration time, and response of the patient. Next up, medication infusion pumps. There are a ton of medication infusion pumps. There are some ambulance services that may carry medication infusion pumps, and you may have to access medication infusion pumps whenever you do an interfacility transfer. IV medication pumps are best used for inotropic medications, for heart failure, or for sepsis, IV nutrition, chemotherapy, IV antibiotics, and really many other medications. Many IV medications are administered with infusion pumps. If the pumps fail while receiving certain vasoactive medications, a life-threatening emergency can occur. Problems related to medication infusion pumps will trigger EMS assistance requests. An underlying medical condition may worsen despite a properly functioning infusion system. Continue current medication infusion while contacting medical control. Most situations will not require titration or infusion pump manipulation. Problems may occur with long-term vascular access devices, and the devices have a limited lifespan. They may become clogged with blood clots or harbor infections, which may lead to issues with the infusion pumps. Mechanical failure or accidental removal may occur, and you may need to reestablish an alternative vascular access. It may be necessary to troubleshoot an infusion system. Electrical outage or battery depletion may be a life-threatening emergency. Of note, most of your infusion systems now are battery operated. So in the case of an electrical outage, it should still have enough power to continually infuse. Device malfunction may cause a sudden unexpected loss of the pump. Solutions include using the ambulance inverter to provide external power, backup devices, calculating a drip rate of IV tubing if the pump cannot be immediately repaired or placed. This is the least preferred. Collaborating with the patient or caregiver for creative solutions. Also, of note, if you are doing an interfacility transfer, you need to make sure that you know what the different alarms on the pump means and how to quickly mitigate alarms such as occlusion alarms. Insulin pumps are electric devices allowing diabetic patients to titrate exogenous insulin needs. They have a potential to complicate EMS treatments of patients with insulin-dependent diabetes who develop hypoglycemia. A general rule of thumb is if the patient is able to manage the pump themselves, or if there is a caregiver or family member, allow them to manipulate the pump, because you don't want to accidentally mash a button that could infuse a bolus of insulin in a case of a patient with hypoglycemia. Tube feeding. There's many different ways that tube feedings can be administered. In the acute setting, typically you may have a nasogastric or orogastric tube. Other types of tubes are implanted, such as a nasoduodenal, and nasojejunal, and both of these are inserted through the nose. They just bypass the stomach, go through the sphincter into the intestine. A gastrostomy, a jejunostomy. So a gastrostomy tube is surgically inserted through the skin into the patient's stomach. A jejunostomy tube is surgically placed through the skin directly into the jejunum of the small intestine. Or you may have a percutaneous endoscopic gastrostomy tube and a percutaneous endoscopic jejunostomy tube. These are placed using endoscopic surgical procedures. EMS personnel do not need to troubleshoot or manipulate feeding tubes. In most situations, if a patient is receiving tube feedings, it's going to be through a pump. Most of the time, you can just disconnect the feeding tube, and for that short period of time, they can actually be fine and maintain fine without continuous tube feeding. If you're on an interfacility transfer, you may have issues such as pump malfunctioning or signs of vomiting or aspiration. You never ever want to lay a patient supine who is receiving tube feeding. Colostomies. A colostomy is a surgical procedure directing the large intestine through a stoma. A colostomy bag or colostomy pouch, as seen here, has a hard circular opening attached around the stoma by an adhesive ring. Stool and intestinal liquid collects in the bag for disposal. There are a few possible problems. The bag separates from the abdominal wall, requiring replacement or temporary reinforcement with tape. The bag becomes full and the patient needs assistance in emptying it. A clamp located at the bottom of the bag opens to allow contents to drain into a suitable collection device. Abdominal gas may also accumulate in the bag, requiring periodic release during longer transports. Another item to note with a patient that has a colostomy bag. Oftentimes, they're going to be very self-conscious. They have no control of their bodily functions when they have a colostomy bag. You must maintain a professional demeanor and remember that you're there to help the patient. Another word of advice, prior to transport of the patient with a colostomy bag, if it is full or is looking like it may become full, make sure that you empty it or have a caregiver empty it before transport. Urostomy, or a urinary diversion system. Urinary diversion is required for certain medical conditions such as bladder cancer, congenital anomalies, or massive urinary tract obstructions. A urostomy is a procedure in which part of the urinary system is diverted through a stoma, which is an opening in the anterior abdominal wall. EMS interventions are similar to those for colostomy: occasional emptying, reinforcement, or reattachment of the bag. Urinary catherization. These are used when patients cannot urinate on their own. They may remain in place, which is called an indwelling catheter, or they may be used intermittently, which is called a straight catheter. Most important with a patient with a urinary catheter, you want to make sure that the bag is empty prior to transport, and you always want to keep the bag below the bladder. You never want to have a backflow of urine into the bladder. If you do, then you're in a lot of trouble. In this skill drill, you'll see how to replace an ostomy device. This could work for a colostomy or a urostomy. First off, you want to empty and remove the current appliance and dispose of it appropriately. Wash the area around the stoma with soap and water. Cleanse the stoma with water only. Place a clean gauze pad over the stoma, because remember, the stoma is still going to be secreting if there is anything to secrete. Cut the wafer to the correct size using the patient's measurement or tracing. Attach the appliance to the wafer. Again, this is all going to be used with adhesive. Remove the gauze. Remove the paper backing from the wafer. Apply the appliance with the stoma centered in the wafer cutout. Dialysis is a replacement for failed or failing kidneys. I once had a friend who was on hemodialysis compare his 3-day-a-week visit to hemodialysis as a 4-hour pee. He would go pee for 4 hours, 3 days a week. Kidney failure is associated with many chronic conditions. As kidney function declines, substances accumulate in the body: fluids, excess electrolytes, and toxins. If untreated, these substances may cause death. Late signs of kidney failure requiring prompt intervention include coma, cardiac dysrhythmia, circulatory overload, and respiratory issues. Hemodialysis and peritoneal dialysis may be performed in a hospital, freestanding dialysis clinic, or at home. Hemodialysis removes blood through a catheter or a fistula. In peritoneal dialysis, the solution is sent through a catheter in the abdomen to draw fluids from the body, and then the fluid is drained. Complications of dialysis include massive fluid and electrolyte abnormalities due to incorrect calculation of the large volumes of fluid moved in and out of the patient's body, hypovolemia or fluid overload, infection. Complications with fistulas include severe life-threatening hemorrhage if a fistula is damaged or a catheter is improperly removed, thrombosis or blood clot, stenosis, or narrowing. Use caution when treating patients who receive dialysis. Overload can occur from small volumes of IV fluids, particularly in susceptible patients. Monitor IV fluids carefully and titrate to patient response. Patients with renal failure are prone to electrolyte abnormalities, especially hyperkalemia, also known as elevated blood potassium concentration. With these patients, you want to avoid medications that are known to increase serum potassium levels, such as succinylcholine, digoxin, or beta-adrenergic blockers. Use caution when the patient has a dialysis fistula because they are prone to clots and infection. You must avoid the same arm that the dialysis fistula is in for blood pressure measurements, blood draws, or IV access. If responding to a dialysis center, determine if treatment has already been received or is still in progress. A significant amount of the patient's blood may still be in the dialysis machine. Carefully coordinate with the dialysis center staff to remove the patient from the machine if dialysis is still in progress. Surgical drains and devices. There are a variety of drains and devices that are used after surgery. Sometimes these devices are sent home and they help to prevent fluid from collecting at a surgical site, thus creating a hematoma. Wound drains prevent fluid from collecting at the surgical site while allowing monitor of draining fluid for volume, appearance, and composition. Other devices use mechanical forces to stabilize the surgical site and promote healing. It is outside the EMS scope of practice to manipulate many of these devices or drains. Doing so can cause significant complications, including hemorrhage, infection, or additional need for surgery. Contact medical control if additional guidance is needed. Other devices paramedics should not manipulate include orthotic devices, prosthetic limbs, or braces. Cerebrospinal fluid shunt. Hydrocephalus is an excess volume of cerebrospinal fluid around the brain. CSF is produced in the brain to protect and cushion, provide nourishment, and remove waste products from the brain and spinal cord. If the brain becomes injured, swelling can be offset by CSF volume reduction to maintain lower intracranial pressure. Approximately 500 milliliters of CSF is produced daily by the choroid plexus of the brain. As it is produced, it is constantly being reabsorbed by the bloodstream. Excess CSF causes increased intracranial pressure, leading to signs and symptoms including headaches, visual disturbances, unsteady gait, nausea and vomiting, seizures, altered mental status, numerous other effects, and enlargement of the relatively malleable skulls of fetuses, infants, and young children without distorting facial features. The shunt consists of an inflow catheter, which is inserted into a ventricle of the brain, and a valve, which is down the line. And then the drain itself is then tunneled down into the abdomen where additional CSF can drain and be reabsorbed by the body. Increased intracranial pressure or signs of increased intracranial pressure, including headache, visual disturbances, or seizures, suggest infection, shunt valve malfunction, catheter damage, or altered mental status. Hemodynamic monitoring. Interfacility patient transports by paramedics follow state EMS regulations and individual service medical directors to determine which medications and procedures can be used. In hemodynamic monitoring, this involves movement and various forces applied to blood within the human body. Cursory hemodynamic monitoring includes assessment of real-time blood pressure, pulse rate, urinary output over time, skin temperature, end-tidal CO2, or mental status. Hemodynamic monitoring provides information regarding perfusion effectiveness. Patients need invasive hemodynamic monitoring when a specific cardiovascular system's effectiveness needs to be evaluated or to carefully guide fluid administration. Monitoring continues as medications are administered, procedures are performed to improve body function or increase chances of survival after critical illness, traumatic injury, major surgery. Invasive monitoring includes values such as continuous arterial blood pressure, central venous pressure or right arterial pressure, pulmonary artery pressure, direct or indirect measurements of left atrial and left ventricular pressure, and systemic vascular and pulmonary vascular resistance. The majority of current hemodynamic monitoring involves placement of different catheter types into different parts of the cardiovascular system, such as arteries, central veins, and various heart chambers. The catheter is connected to special tubing, usually filled with normal saline or a heparinized solution. The solution is placed on a pressure bag to prevent blood from being pushed out of the body through the catheter and tubing. The tubing is connected to a transducer that converts fluid pressure changes into electrical impulses. Impulses are interrupted by the monitor and displayed as waveforms and numeric values. One of the most common types that you may hear of is called a Swan's-Ganz catheter. Invasive monitoring will identify impending heart failure, guide fluid resuscitation, demonstrate effectiveness of CPR compressions, differentiate various shock states, and provide useful information in high-risk patients. Arterial pressure monitoring is a component of hemodynamic monitoring. Arterial lines, also known as ART lines, are used to monitor blood pressure and provide continuous access for frequent blood tests or arterial blood gas sampling. Conditions requiring frequent blood tests include sepsis, respiratory failure, diabetic ketoacidosis, or salicylate overdose. Larger arterial sheaths may have been placed for cardiac catheterization. These sheaths are placed in a femoral artery. They provide a route to the cardiac blood vessels. They are occasionally left in place after diagnostic cardiac catheterization if the patient is to be transported to another hospital for further invasive cardiac care. Patients should remain supine with legs straight during placement and for a time after placement. Bleeding from displaced arterial catheter or sheath can be immediately life-threatening. The patient must be continuously monitored. Large quantities of blood can become lodged in the groin area and stretcher linens before being seen. Intra-Aortic balloon pumps, or IABPs. These are used to decrease cardiac workload and augment perfusion in patients with cardiogenic shock, structural abnormalities in the heart, myocardial infarction, or cardiac surgery. It is unlikely that a paramedic will be solely responsible for care, but he or she may accompany a critical care transport team. IABPs consist of a relatively large machine, the connecting tubing, monitoring cables, a balloon catheter, which is a cylindrical balloon inserted through the femoral artery into the aorta. The tubing connects the catheter to the machine. Monitor leads from the machine are connected to the patient. Movement of both patients and machine requires careful planning and coordination. The balloon is inflated and deflated at precise times during the cardiac cycle. The balloon inflates during diastole, pushing blood forward into systemic circulation. The balloon actively deflates during systole, creating a brief vacuum and reducing cardiac afterload. The process works to decrease myocardial oxygen demand, reduce cardiac workload, and improve systemic circulation. An intra-aortic balloon pump is bulky and difficult to move and secure in an ambulance. You will need additional straps to prevent the machine from moving in the event of a crash. Be careful when handling and securing the connecting tube. Accidental removal of the balloon catheter often creates a life-threatening emergency.
Intra-aortic balloon counterpulsation or intra-aortic balloon pump, that is a device that increases blood flow to the coronary arteries, which in turn increases blood flow and oxygen to the myocardium, the muscle of the heart. So this is how it works. It basically helps the body out. It gives the heart an extra beat, so to speak. So this is placed in the aorta, and systole is when the heart contracts, and so when the left ventricle contracts, then blood is ejected out of that left ventricle into the aorta and to the rest of the body, just like normal. And so during systole, everything is normal, and the balloon is not inflated. Now, when the heart is at rest, that's when the balloon inflates. And so when the balloon inflates, it displaces all of the blood that was in this location is now displaced. It's now pushed this way and down. It's pushed back up and it's pushed down. So the blood that is displaced upwards, it comes back up and feeds the coronary arteries. Remember, the coronary arteries are in here-ish. They're the first branches off the aorta. And so when the balloon inflates, it pushes blood back up to the coronary arteries. And so that's how a balloon pump increases blood flow to the coronary arteries, and then, of course, from there to the actual heart muscle. This is a video kind of just demonstrating how the balloon inflates when the heart is resting. And so again, when the balloon is inflated, it pushes blood back to the coronary arteries to help perfuse the coronary arteries. So again, the balloon inflates during diastole and deflates during systole.
Intracranial pressure monitors. An intracranial pressure monitor or drain may be placed in patients with intracranial hemorrhage, with severe head trauma, or who have undergone neurosurgery. Devices allow intracranial pressure monitoring, evaluation of the appearance of CSF, or drainage of CSF to maintain lower intracranial pressure. Monitoring ICP is similar to hemodynamic monitoring. The transducer of the drainage system is typically aligned at the same height as the patient's ear canal. This may be difficult in a crowded ambulance. The drainage system positioning is extremely important. Improper placement can cause large volumes of CSF to quickly enter or leave the patient's nervous system. Doppler devices use ultrasound waves to detect heartbeats and blood flow where palpation and auscultation are not effective. Waves are converted into sounds that allow confirmation of underlying movements and are used to detect and calculate fetal heartbeats in pregnant patients, detect pulses in compromised extremities, and obtain blood pressure or pulses that are too weak to palpate. To use, place a water-based gel between the probe and the patient's skin over the appropriate area and move the probe slowly until you detect the underlying flow or movement. This concludes our discussion of medical devices that you may see in the pre-hospital field. Again, this was just an introductory presentation. For more information, you must seek additional training for the particular device. In our next section, we will discuss care of patients with cognitive, sensory, or communication impairment.